Do you know what your ideal body weight is? I think you calculated it several months ago.
56.
Do you remember?
I don't know.
30.
Caroline, do you remember your ideal body weight?
No, I don't
No?
know.
How tall are you?
5'2".
You're 5'2"? All right, so 105 plus 5 times 62 minus 60, so that's 2. 5 times 2 is 10. So 105 plus 10, what does that give you?
115.
All right, now divide that by 2.2.
Thank you.
Okay, when you divide it by 2.2, you get your kilogram ideal body weight. And now to find out what your normal tidal volume is, multiply it by 5 mLs, write that number down, then multiply it by 7 mLs, and then write that number down. Anita, you finished? What is your normal tidal volume?
The range is 261 to 366.
260 to 360? Susie, did you get yours?
Yeah, I had 260.
Okay. Raj?
400 to 560.
Okay. So we can't just assume everybody has the same tidal volume. So it's going to vary because of your height, male versus female. And what about Martine?
284 to 397.
All right. So that gives you an idea of what normal tidal volumes are. And you'll do the same thing with your patient on the ventilator. When they're breathing spontaneously, you take a look at their volume and decide if that's normal for their ideal body weight. If their spontaneous tidal volume is less than 5 mLs per kilogram, that is not normal. So spontaneous tidal volume less than 5 mLs per kilogram is not normal. All right, so minute ventilation is the air going in and out of the lungs per 1 minute. And there's 2 components to minute ventilation, blank and blank. So what do you put in there? Very good. Respiratory rate and tidal volume. A normal minute ventilation for an adult is about 6 liters a minute. At how many liters do we consider the patient to have a high minute volume? And the answer is greater than 10 liters per minute. So you can write down that sick lungs have a high VQ mismatch. Sick lungs have a high VQ mismatch and require a higher VE, or require a higher minute ventilation to maintain a normal ABG. So sick lungs have a higher VQ mismatch and require a higher minute ventilation to maintain a normal ABG. So if your lungs are healthy, you get 6 liters a minute of air in and out of your lungs, and if we draw some arterial blood from you everything's going to look normal. Normal CO2, normal pH, normal oxygenation. But then patients that have pneumonia or atelectasis, and there's something going on with the lung parenchyma, and now there's areas that are not getting ventilated very well. So there's ventilation and perfusion mismatch. They're going to have to breathe a lot more minute ventilation just to keep their blood gases normal. Does that make sense? So if they're having to move more than 10 liters a minute, and then you draw their arterial blood and it's normal, that gives you a clue as to how bad their lungs are doing. Some patients require 25 liters per minute to maintain normal blood gases. How does this reflect on the condition of their lungs? What do you think you should write for that? Very high VQ mismatch, right? Okay, respiratory rate, it's RR typically, unless you're working with the 840 ventilator. They call the respiratory rate the F, or the frequency. For adults, 12 to 16 breaths per minute is a normal respiratory rate. At what rate do we consider the patient to be tachypneic?
Greater than 20 breaths per minute?
Greater than 20? Okay. What are the implications if the respiratory rate is greater than 30 per minute? And not just like the patient sees their family and they start breathing fast because they're excited and they want to try to communicate with the family, but sustained 30 breaths per minute. It's been 15, 20 minutes, so breathing 30 times a minute and it's not slowing down. So the implications are I have several things written down here. One, respiratory distress. They may be, and then we're going to write down all the possibilities of why a patient would breathe 30 times a minute. Maybe high VQ mismatch. And then it keeps going. Hyperventilating. Pain and anxiety. It could be that they're hypoxemic. A really low PaO2, like PaO2 below 60, will cause hyperventilation because the body's trying to get more oxygen by breathing more. So possibly hypoxemia. And then there's one more. Metabolic acidosis. So if the pH is acidotic, the way that the body is going to try to normalize the pH is by getting rid of carbon dioxide. So if you get rid of carbon dioxide, you're getting rid of acid, and that can normalize an acidotic pH. So metabolic acidosis is going to make the patient breathe faster to try to get rid of CO2, get rid of acid. What about what?
Respiratory acidosis.
It should, right? When there's a respiratory acidosis, it shouldn't be, because the patients should be breathing fast enough to maintain their normal CO2. So respiratory acidosis should lead to a fast respiratory rate to get the CO2s back to normal. But typically, there's a respiratory acidosis for another reason. Either they're heavily sedated, and it's knocking out their drive to breathe. They've completely fatigued. So there's different reasons for why a patient would have respiratory acidosis. Because you would think, okay, CO2s are up, they should breathe fast, blow it off, and now they've got a normal CO2. But there's something causing them to not have a normal CO2.
So in this case, it would not be only metabolic acidosis.
Yes. What ventilator change would you recommend if the respiratory rate is greater than 30 breaths per minute? The answer is change to a full support mode to minimize work of breathing. Change to a full support mode to minimize work of breathing. All right, with lung compliance, this is used to trend the condition of the patient's lungs. A slow change in static compliance over 1 or 2 shifts may indicate that fluid is accumulating in the lung parenchyma. So typically what happens is the kidneys can malfunction and the patient stops producing urine. But they're still getting IV fluids. So the IV fluids go into the veins, and now the kidneys aren't working to get rid of the extra fluid. Where's all that fluid going to go? Well, fluid loves to accumulate in the interstitial spaces of the lungs. It loves to accumulate in pleural spaces. And then some of it we see, like we'll see leg edema with it, or just edema, generalized edema is where the fluid goes. So when fluid accumulates in the interstitial spaces of the lungs, it makes the lungs stiff. So if that starts happening, let's say you start the shift, the patient's doing great and good urine output, and you get a plateau pressure and you write it down. And then you're there 12 hours. 12 hours later, urine output has really decreased. Still getting their fluids, and now you do a plateau pressure. You're going to notice your plateau pressure is higher than it was 12 hours ago because fluid is accumulating in the lungs. Or the patient may be developing ARDS. Have you had that in your disease class yet, what ARDS is? No? So a trauma to the body causes a lot of inflammatory mediators to be released in the lungs. And when you get those inflammatory mediators in the alveoli, in the interstitial spaces, it causes a lot of edema. It washes out the surfactants. Alveoli start to collapse. So that's ARDS. So you'll learn about it coming up soon, I'm sure. So when that happens, the alveoli become stiff, and you'll notice that your plateau pressures will be higher. So ARDS, stiff lungs, higher plateau pressure. You want to write that? Yeah?
So that was the answer on the test question, was the answer increase airway resistance then? Because if the plateau pressure stays the same, then it would be airway resistance. Okay.
Did you get that right?
I did.
All right, so ARDS means stiff lungs, which means higher plateau pressure. If you have a fast change in your static compliance, that indicates a possible pneumothorax. Calculate static compliance. You guys have done this, so I'll skip past it. Resistance. Name some causes of increased airway resistance. You probably can say this in your sleep by now, can't you? Bronchospasm. Secretions. Small ET tube or biting on the ET tube. Cough. Curved tube. Yes, it's true. Very good. Did you mention bronchospasm?
Yeah.
You did. Okay. So how is resistance monitored in volume modes of ventilation? Remember your airway resistance formula? The peak pressure minus plateau pressure. So the bigger the two, the bigger the distance between those two, more airway resistance. So peak pressure minus plateau pressure, and then you divide by flow. In a pressure mode of ventilation, it asks how is resistance monitored. There is no way to monitor airway resistance in pressure modes of ventilation. So you can't get airway resistance numbers in pressure modes of ventilation. If you have more airway resistance, you'll get a smaller tidal volume delivered, but there's no way to say whether it's from airway resistance or another reason. Workup reading is another number that shows up when you go to, on the servo I, if you keep hitting more pages or next pages, it'll show you all these values. One thing it shows you is work of breathing. So the ventilator is estimating work of breathing depending on airway resistance and lung and plateau pressures. You don't have to calculate it. It looks at the area in the pressure volume curve and decides what the work of breathing is. So work of breathing is pressure times volume. No, you don't have to calculate it. Just so that you know, the two components that are used to calculate work of breathing is the pressure that it takes and the volume that's delivered to the lungs. With airway resistance, it says PTA divided by flow. So we know airway resistance as peak pressure minus plateau pressure. Well, that pressure difference is also called PTA, or trans-airway pressure. We learned about trans-airway pressure in the beginning of the semester. It's the difference in pressure between the mouth and the alveoli, trans-airway. And the way that you figure out trans-airway pressure is just looking at your peak pressure on inspiration, do a plateau or an inspiratory hold, and get your plateau pressure. So just more fancy terms for the same thing.
Delta P.
What's that?
Delta P?
Not delta P, but peak pressure minus plateau pressure. Yeah. And then sometimes instead of ventilator manufacturers talking about lung compliance, they talk about elasticity of the lung. And to get elasticity, you do 1 over the compliance and you come up with elasticity. So it's like the reciprocal of compliance. And that's it.